session this morning. The other moderator for the session is Christine Comer, and we have two speakers for you this morning, and we're going to hear about radicular pain and the pathway for that. Thank you for joining us, and I'll hand over to Christine, who's going to introduce the first speaker.
Thanks, Elaine, and it's a pleasure to be here this morning and to introduce Professor Nadine Foster, our first presenter. Many of you know that before her recent move to Australia to take up her new role as Professor and Director of the STARS Education and Research Alliance at the University of Queensland, Nadine was NIHR Professor of the Musculoskeletal Health in Primary Care and the Director of Keele Clinical Trials Unit. She's led and collaborated on more than 16 randomised trials and is known internationally for her impact on research into common pain conditions in primary care, including low back pain. She's also been a previous president of the Society of Back Pain Research. So we'll now enjoy Nadine's presentation about the SCOPIC trial evaluating stratified versus usual care for patients with sciatica.
Hi there, everyone. I'm just going to share my screen. And my presentation is focused on stratified care for sciatica in primary care. And I'm going to share the results from the SCOPIC trial, which we've just recently finished. And I'm very much doing this on behalf of a very large interdisciplinary trial team, the SCOPIC trial team. So the basis for this trial was trying to work out how to improve on the current management of patients with sciatica in primary care. And as you know, if a patient like this consults in primary care, very few, but some, will proceed to have either an urgent referral or admission to hospital. The vast majority of patients with sciatica are managed in what we might call a stepped care approach, where first of all, I perhaps offered some self-management advice and support to self-manage. They may be managed then with medications if that first step doesn't work. Often if they then reconsult and the medications aren't working, they may be referred for a course of physiotherapy and so on, essentially then stepping up to spinal specialist assessment, including a scan and consideration for invasive treatments. And a challenge with this sort of stepped care model is that essentially patients have to feel steps at the lower end before they're then stepped up to the next level of care. And that can be very frustrating for patients and very inefficient for the healthcare system. As many of you will know, our team at Keele developed a stratified care model for non-specific low back pain some years ago, where we developed one index of risk in one screening tool called the Start Back screening tool to identify patients at low, medium and high risk of persistent pain and disability. And then using those three subgroups and matching them to treatments, we were able to demonstrate that you can make healthcare more efficient and yield patient benefits if you work in this new way, so moving away from a stepped care and towards a stratified care model. But the key thing about our suite of stratified care studies, so our Start Back and Impact Back studies, is that they weren't specifically developed for sciatica. So whilst in these two large previous studies of nearly 1,000 patients in each, we didn't exclude patients with sciatica, we didn't specifically look at them as an important subgroup. And so we're not really sure that that model of stratified care works for patients with sciatica. So the SCOPIC trial, or sciatica outcomes in primary care, aimed to compare the clinical and cost effectiveness of a new approach to stratified care versus non-stratified care for patients in primary care with sciatica. Specifically, what we wanted to find out is, does stratified care lead to faster resolution of sciatica symptoms? So to go back in time a little bit, first we had to develop a stratification algorithm. And the challenge in this field is that there's very little good evidence that there are consistent predictors of outcome that are specific to sciatica. And so really what we try to do is work forward from that poor evidence base to develop a sensible clinical stratification algorithm. And the way we approached that was to combine the best of what we know in terms of prognosis from the work that we'd already done in StartBack with what you might call sensible clinical indicators of sciatica severity from the clinical assessment. And how do we go about this? Well, Kika Constantinou and colleagues and I at Keele worked together using data from a large cohort of sciatica patients consulting in primary care. And that was the Atlas cohort there on the far left. So we identified that of over 600 patients in that cohort, 427 had a clinical diagnosis of sciatica. And of those, over the course of 1 year, 57 were referred to spine specialist care or spine specialist services for further assessment and consideration of more invasive treatments. So what we try to do using that data is predict who are those patients. So could we identify those patients earlier on that they're going to end up in essentially seeing spinal specialists? And so we moved forward then with this combined algorithm. So using the StartBack tool that we already had, while it's not specifically developed for sciatica, it does work quite well for patients with back pain. So we used that tool, and then we tested out whether we could add clinical assessment findings that seem to make clinical sense from the data from Atlas and see if we could improve the prediction of who gets referred to spine specialists. And so we ended up with 4 clinical indicators of sciatica severity in the algorithm. First was those patients who had intense leg pain, those who had a sensory deficit, those who were reporting interference with their ability to do their job, and that included jobs at home. And the final 4th point was also pain below the knee. And again, not to go into lots of details, this paper is published and it describes the way we went about developing this algorithm and doing some internal validation in the Atlas cohort data set. So that was our approach to subgrouping. And this slide summarizes that. It looks quite complicated, but by and large, we use the StartBack tool to decide whether patients are at low risk or on the right, medium or high risk. If they're at low risk there on the left, they go straight into group 1 in this new sciatica stratification algorithm. And they're matched to a brief self-management support session in up to 2 sessions of that. And then going back over to the right, if patients are medium or high risk of persistent pain and disability using the StartBack tool, we then use their psychological subscale score on the StartBack tool to then help us work out whether they would then proceed to group 2 or group 3 in this new sciatica stratification algorithm. And this is where we combined information on prognostic risk with those 4 severity indicators of sciatica. And you'll see there that we've ended up then with 3 groups. The first group get a brief self-management 2-session intervention. The second group get a course of physiotherapy of up to 6 sessions. And the third group are those that are referred to MRI and specialist spinal services, if you like, a fast-track pathway, including MRI and access to a spine specialist further assessment. So we rolled forward then into the scopic trial design, and this is a very simple 2-arm parallel controlled trial. We needed 476 patients with sciatica, and we identified those from 42 general practices in 3 geographical areas. And the trial involved 5 different physiotherapy services, so big undertaking. And the 2 arms of the trial, firstly, stratified care, where we used the algorithm that we've just described in order to match patients to different care pathways that I've just described, or usual non-stratified care, where there was no systematic subgrouping tool used, nor any screening tool or risk stratification tool. So it's really very much usual non-stratified care. How did we go about getting patients into this trial? So if you look at the far left, patients consulted their GP with back and leg pain and with a suspected diagnosis of sciatica. And if the GP entered low back pain or sciatica into their read code system on the computer, we built in a pop-up screen using our health informatics expertise to help with recruitment in those real-time consultations. And GPs were to assess the potential suitability for patients for the trial. And essentially, the GP was asked to answer the following questions. Does the patient have sciatica or might have sciatica? And is this patient suitable for invitation to the Scopic trial clinic? The patients who were then suitable were received the invitation and clinic information, and via telephone were booked in to see the clinic where they were assessed by musculoskeletal physiotherapists, who then made the clinical diagnosis of sciatica and finally screened patients for eligibility. So who were we looking for? Well, they had to be aged 18 years and over with a clinical diagnosis of sciatica, they had to have a mobile phone or access to a landline telephone, and able to read and communicate in English. We excluded those who had possible serious spinal pathology, such as suspected cancers, infections, and so on. We excluded those who had previous lumbar spine surgery, those who didn't have sciatica symptoms, those who currently were receiving or had received in the last 3 months physiotherapy or secondary care for the same problem, those with very serious comorbidities, or those who were pregnant. So then turning to our primary outcome measures. So in this trial, as I mentioned earlier, we were interested in time to resolution. And we defined that as time to first resolution of symptoms, and we collected that using brief text messages, collected every week for the first 4 months of the trial, and then that dropped down in frequency to every month for the remaining 8 months of the trial. If the patient reported 2 consecutive responses where they indicated resolution of symptoms, that was taken as sustained resolution, and the text messages did stop at that point. As you would imagine, in a trial like this, we collected a lot of other data. But first, before I get onto that, I'm just showing there the question around their resolution. So compared to how you were at the clinic X weeks ago, how are your back and leg symptoms today? And they were texted these little prompts on their mobile phone, and they simply responded with a numerical response. The secondary outcomes at 4 months and 12 months follow-up were collected by postal questionnaire and included a whole range of secondary outcomes, including disability, psychological measures, process outcomes, quality of life, healthcare use, and data on their work. We also built in a health economics plan into the trial in order to do an incremental cost effectiveness analysis alongside the trial using a UK national health perspective. The primary outcome measure for the health economics, of course, was the quality adjusted life year, or the QALY. And we derived data, of course, from the EQ5D in those questionnaires at baseline, 4 months and 12 months in order to calculate the QALYs. The analysis was adjusted for imbalances in the baseline EQ5D scores between the 2 trial arms. We also collected intervention costs as part of the RCT, including the number and duration of treatment sessions. The MRI scan and consultation with spine specialists was also included in the costings. We asked patients to tell us about their self-reported resource use data over the follow-up time points, and included everything you would imagine it would, including their primary care contacts, prescription data, hospital contacts, investigations, private health care, and work-related outcomes. And then costs over 12 months were generated by multiplying resource use items by unit cost. In terms of the clinical analysis, our primary analysis was time to event. So it was a survival analysis essentially, but the event was, of course, resolution of symptoms. And we defined that as either completely recovered or much better using their responses on the SMS text messages. We also conducted several exploratory analyses and secondary analyses And we focused also on some process outcomes, such as referral patterns, time to treatment, and the treatments received. The trial had a nested qualitative interview study where we conducted individual interviews with a sample of both patients in that fast track pathway, so group 3. That's the group of patients receiving fast access to an MRI and to a spine specialist for further assessment. And we also conducted individual interviews with a range of our clinicians, GPs, spinal physiotherapy specialists, and spinal surgeons. Okay, so on to the results of the trial. Well, firstly, just to give you a sense of the sheer enormity of the endeavour behind some of these trials, in order to identify our sample of over 400 patients, we started off by sending out clinical invitations by mail to almost 3,000 patients who had consulted at those 42 practices with suspected sciatica. And then we went through our processes of screening in order to invite 1,269 to our scopic trial clinics. And that's, of course, where they were then further screened in detail against the inclusion and exclusion eligibility criteria. So from that 1,269, following screening, we ended up, of course, with our 476 patients. And although that looks like a lot of patients not entering the trial, it was in fact 88% of those patients who were deemed eligible following the detailed screening. And you can see there on the right-hand side that the vast majority of patients that were not included as eligible, the reason for that was because there was low confidence in the fact that they actually did have a sciatica diagnosis. So then on to the trial detail and the flow over the trial. So our 476 patients randomized either on the left to stratified care or on the right to usual care. And if I just draw your eye to the proportions of patients in each of the 3 stratified subgroups, so group 1, group 2, and group 3, you can see that about 22% of patients were in that group 1 and therefore receiving our self-management advice and support in up to 2 sessions. About 44% were in group 2 and in stratified care we're going on then to have our course of physiotherapy as their intervention. And about a third of patients were allocated to group 3 and were then on that fast track pathway in the stratified care arm to an MRI and spine specialist assessment. We had reasonably good follow-up over 4 months and 12 months in terms of our postal questionnaires. But the primary outcome follow-up, of course, remember, was collected by SMS text messages, and we had very good response rates to that. So 88% in the stratified care arm and 90% for our primary outcome in the usual care arm. These next slides describe the patients in this trial, and I won't go into lots of detail, just to reassure you that the trial randomization did result in reasonably well-balanced groups in the 2 arms of the trial. So on average, patients were about 51, 52 years of age. Just over half of folks in the trial were female. Their RMDQ scores started off at around 11 out of 23, and back pain of around 6, leg pain of around 7. 70% in one arm, 66% in another were currently employed, and approximately half or slightly more had taken time off work recently because of their sciatica. In terms of symptom duration, you can see here that we had a really good proportion of patients in this trial who had what we might call an early episode of sciatica. So 40, I guess nearly 50%, if you define that as 6 weeks or less of the patients in this trial in terms of the pain duration. We also collected clinical assessment findings. So, for example, pain on straight leg raise, sensory changes, neurological deficits, all described on this slide. And again, more or less, we identified that we had ended up with reasonably balanced groups in terms of these clinical assessment findings. and a little bit more detail here. So then on to the primary outcome results. Now remember, the primary outcome in this trial was time to symptom resolution. And so the way that you analyse this and the way you report this is using a hazards ratio. So I'll just talk you through this graph. So along the y-axis there, you have the cumulative proportion of resolved cases going up from 0 to 1 or 0 to 100%. And along the x-axis, you have the time over that 1 year follow-up. And what you have here in these two lines, the black line and the grey line, the black line is a stratified care arm and the time to symptom resolution. And the grey line is the usual care group and the time to symptom resolution. And you could probably see here, it's hard to distinguish these two lines because essentially in terms of the patients in each arm of the trial, on average, followed quite a similar path to symptom resolution. And the hazards ratio down there in black was 1.14, and you can see that the confidence interval included 0, which means that there was no statistically significant differences in time to resolution between the two arms of this trial. I think the little bit of separation that you see there around 8 to 12 weeks is probably as good as it gets in these trial results. And that played out when we looked at the median time to resolution. So it took on average 10 weeks in the stratified care arm to reach symptom resolution, and that was 12 weeks in the usual care group. So a median of 2 weeks difference. From a statistical significance point of view, that was not statistically significant. I suspect we'll all have different views about whether that's clinically important. And of course, patients may have a different view. But from the trial's perspective, this difference was not statistically significant. And then when we looked also at what happened by the end of the year, so by week 48, 72% of patients overall had reported resolution. And again, it was pretty similar in the two arms of the trial. It was slightly higher in the stratified care arm than in the usual care arm. Again, I won't press the point on lots of secondary outcome results because essentially the results do not change the conclusions from the primary outcome analyses. So whether we looked at low back pain, leg pain, disability, interference with home and work activities, or mental health outcomes such as depression, we saw patients in this trial improve over time on average, and there was no difference between the arms of the trial across these range of outcomes. That was also true of perceived change at 12 months. And when we looked at our sciatica subgroup analysis, we then wanted to compare those in group 1, 2, and 3 managed using stratified care versus usual care. So when we look at our group 1, so this is the group who were not at risk of poor outcome, and what we see here actually is that they did slightly better in usual care than in stratified care. But again, not statistically significant. When we look to group 2, the group that went on to have a course of physiotherapy for their sciatica, we see that flip. So patients receiving stratified care in this trial had a median time to resolution of 9 weeks, and that was 12 weeks in the usual care. So it did seem, just looking at that graph, that stratified care was doing something beneficial, perhaps for the patients, particularly in this group. Again, this is a subgroup analysis, and these differences were not statistically significant. And then group 3 are those patients who were on our fast-track pathway to MRI and spinal specialist assessment. And I think you can clearly see, looking at the lines of this graph, that there was no difference. So it took a median of 16 weeks to resolution in stratified care, and that was 15 weeks in usual care. So what about process of care data? So the time to first physiotherapy appointment for those who were having physiotherapy was 9 days in stratified care versus 21.5 days in usual care. So I think what that tells us is that our stratified care pathway did work in that patients received physiotherapy or started to receive physiotherapy more quickly in the stratified care arm than in the usual care arm. And similarly, when we look at time to spinal specialist clinical consultation for those same specialists, that was very different. It was 12 days in stratified care versus 115 days in usual care. So again, if you're asking me, well, did the stratified care process work? We got patients to what we felt was the right destination more quickly. That did happen. In total, over the course of the trial, 30 patients reported having received a spinal injection in the stratified care arm, compared to 15 in the usual care. And they did receive these more quickly. So those who had spinal injections received them on average by 60 days versus 161 days in usual care. And although the numbers are very small who proceeded to have surgery, 5 in stratified care versus 8 in usual care, we didn't see any difference in their time to treatment. So that was largely similar in the trial. What about our health economic results? Well, I'll just try to cut to the chase with some of these results. So highlighted there in the little circles in red are our unadjusted QALYs. And you can see in the stratified care column, that was 0.659, usual care 0.671. So actually, for health-related quality of life, measured by the EQ5D and translated into this thing called a QALY, usual care was actually doing better for patients. Just very, very small, not statistically different, but slightly erring on the side of patients on average being better with usual care than stratified care. And in terms of our cost effectiveness analysis then, what did that mean in terms of costs? So offering stratified care in the way that we did was on average £46 more expensive per patient, although with wide confidence intervals, than what we were doing in usual care. And so essentially, when we combine those additional costs, higher cost with a slightly lower quality of life, what we end up here is seeing that our stratified care model was something called dominated by usual care. And I'll maybe just show that in this cost effectiveness plot. So if you think about all those little dots, and they're kind of like a swarm of bees, I always think, where do they land on this figure, this quadrant? And there's a lot of uncertainty, as you can see, and they're not neatly in any one of those 4 corners of the graph. But by and large, most of those dots land in that top left corner. And that means that this new way of working was slightly more expensive and led to slightly lower quality of life for patients. And that's what we mean by dominated. And indeed, then when we looked at whether this new stratified care intervention might be cost effective at the various willingness to pay thresholds that we typically use in the UK, let's say if we look along that x-axis at £20,000 per QALY, we can see that this intervention has a very low probability of being cost effective for the NHS. We did do those qualitative interviews, and again, in the interest of time, I can't cover all of the results, but I've picked out a few main themes. Firstly, the timeliness of the fast track care pathway for patients in that group 3 subgroup. Then the waiting times for onward referral following the fast tracking process. And finally, the perceived benefits of the fast track care pathway. So all patients interviewed reported being pleased and surprised by the speed in which they were able to then receive their MRI scan. And they drew contrast with their previous experiences of longer NHS waiting times for treatments and tests. And here's an example quote from that from a patient. I went for my scan more or less straight after. I even commented how quick it was because normally you wait and wait and wait, don't you? I was shocked and pleased because it seemed like I'd jumped the queue. 7 clinicians, comprising 4 surgeons, 1 spine physiotherapist and 2 GPs, find it acceptable for patients with short symptom durations to be fast-tracked as early as possible. But largely when we explored why they thought that was acceptable, it was largely because they felt this would provide reassurance for patients rather than necessarily to inform their treatment decisions. For these clinicians, providing reassurance to patients was seen as enough benefit in itself to warrant early investigation for acute short duration patients. And again, here's a quote from a spinal surgeon. "I don't think getting MRIs done earlier would be a bad idea. Patients like to have that reassurance. So I think the MRI scan is more of a tool to address their mental state rather than to decide on treatment. I don't think it will change my decision-making or time to treat." 13 clinicians, comprising 7 GPs and 6 physiotherapists, did express concern, however, that patients with short symptom durations, and by that they meant those with episodes of under 6 weeks, that they were concerned that they may be fast-tracked too soon and symptoms could still resolve naturally. So here's a GP who says, "My cutoff is if things are no better after 6 to 8 weeks, then it's looking more like a chronic issue that's maybe not going to resolve easily or quickly. So patients are being fast-tracked for a scan earlier than I would. Potentially you may be seeing people that would have gone on to just resolve in another 2 or 3 weeks." Whilst views varied on the suitability for fast track of patients with less than 6 weeks of symptoms, most expressed reluctance to consider invasive treatments too early for these patients. And this appears to reflect the extent to which the current stepped care model that I mentioned at the start is really embedded within usual care. Here's a spinal physiotherapist who says, "If they've not had appropriate conservative treatment, I wouldn't want to rush down those invasive management options too early. Anyone with less than 2 months or even up to 10 weeks worth of symptoms, I'd like them to have longer to settle conservatively beforehand." For patients having been fast-tracked for an MRI and spinal specialist opinion, they expected to also receive the onward treatment in a shorter time frame. And as a result, joining usual NHS waiting lists at
first
that
of all,
stage
perhaps
did lead
offered
to a
some
degree of
self-management
frustration
advice
and distress.
to self-manage. They
This
may be
patient
managed.
says, "Because of the speed I went from the doctor to the clinic, to the MRI, to the specialist, I thought, yeah, there's got to be something wrong here for them to have spent the 9 hours on treatment to get me to this point. And then for it to stop, you think, well, where do I go from here? Who can I talk to just get things moving?" Clinicians in all 3 groups suggested that not being able to influence the timing of onward referrals once patients, if you like, were then deemed suitable for these invasive treatments, such as injections and surgery, they felt it was a great limitation of our fast-track pathway. This physiotherapist says, "We can fast-track to a point, but we can't then influence the speed with which the next step, the next intervention occurs. So if we do deem that person as being appropriate for having an injection, but then there's a 10-week waiting time for injections, that's out of our hands. So whilst we can get them to this point quicker, we can't then necessarily get them onto the next stage any quicker." However, there was also an acknowledgement that as a result of being fast-tracked, the overall time period for receiving onward treatments would be less for individual patients. Here's a GP who says having an MRI scan at an earlier stage and then being seen by a spinal specialist without having a 3, 4, 5, 6 month wait to get to that point is better for the individual if they're going to require the intervention, even if they have to then wait to actually receive the onward treatment. So hopefully, having been fast-tracked, their symptoms will be resolved more quickly and they can get back to work or their usual activities. Both patients and all 3 clinician groups perceived benefits from the fast-track pathway in providing that earlier patient reassurance based on MRI scan findings. Here's a patient who says, "I was happy when I had the MRI because I knew what it was. I think that's half the problem because you worry about it otherwise. But he, the spinal specialist, showed me the MRI scan and exactly where the disc bulge was. so that you knew exactly what was going on. I know what I'm coping with, and I just feel easier now. That's 90% of the battle, really, that I know that it's nothing too sinister. And here's a spine specialist, a spine physiotherapist, who says with a lot of these patients, it's the first episodes of these types of problems that they've ever had. So there is a huge amount of anxiety. And one of the benefits of fast tracking them is that we can show them, yes, there is something. Because if they've had a scan, that confirms the changes. There's nothing sinister or nasty going on. So you can offer a level of reassurance. So really then, overall conclusions of this large trial. Firstly, this stratified care model, combining prognostic information using the START Back tool with those 4 clinical indicators of sciatica severity. When we compared that model to usual care, we saw that it led on average to 2 weeks faster improvement, so 10 weeks versus 12 weeks. But that was not statistically significant. Our stratified care model was not more clinically effective than usual care control. On average, patients in both arms of the trial improved in a similar way over time, although please don't forget that about 25% did not report symptom resolution during any follow-up time point over 1 year. In conclusion, therefore, this model of stratified care led to slightly fewer quality adjusted life years over 12 months, or health economic outcome. It was associated with slightly higher costs over 12 months. Remember that we were sending about 1/3 of patients on the fast track pathway who were getting an MRI and a spinal specialist consultation. So the fast track pathway was more expensive, but not more effective. What are the potential explanations of this trial? Well, firstly, I think the message to take is that patients with sciatica in primary care, on average, generally have good outcomes over time. We saw on average 75% of our sample reporting resolution of symptoms over 12 months. Another potential explanation for the results of the trial is the limited performance of our stratification algorithm. I talked through how we went about doing that at the beginning of this presentation, and very much we were offering it as a first step to try to work out how we might stratify patients with sciatica. But there is no doubt that the performance of that algorithm is less than ideal, and that means that a number of patients who were fast-tracked in that group 3 might not have needed that. A third explanation is the effectiveness of usual care in this trial. So when we look at the comparison lines that I showed you on time to resolution, patients in usual care in this trial on average were also doing quite well. And of course, in randomized trials, that makes it really tough to show superiority of the new way of working. And finally, that key point that came out of the qualitative data from the trial is clinicians' reluctance to consider invasive treatments early on. So even where patients were fast-tracked, even where patients in that group were felt to be suitable for more invasive treatments, such as spinal injections or surgery, there was still a reasonable degree of clinical reluctance to move patients onto that until a sufficient length of time, if you like, had happened. So essentially, clinicians are kind of steeped in our stepped care model. So what does this mean for future research? I think what's clear to us as a team is that it would be well worth investing more research time to try to better identify consistent factors that predict outcome or treatment response in patients with sciatica. We really need that information to better inform better models of stratified care for the future. And in the meantime, and before then we can develop better prognostic models, then perhaps testing ways to systematically deliver care for patients with sciatica could help to reduce the unhelpful practice variation that currently exists in our clinical practice in the UK, and perhaps better implementation of our, for example, back pain, sciatica pain pathways. I'd like to just point out that all of the research that I've presented has now been published. So the trial protocol, the stratification algorithm, and most recently, just recently in the Lancet Rheumatology, the randomized controlled trial clinical findings and cost effectiveness findings. I should add also that our qualitative results have just also recently been published. So I'd like to finish by all of the acknowledgements. This has been a huge endeavour over many years. So the patients, the physiotherapists, the surgeons, the GPs, a very large and interdisciplinary clinical trial team. The funders of this trial were the NIHR, the National Institute of Health Research, Health Technology Programme. And I'd also like to just finish by thanking you very much for your attention. And I look forward to discussing the trial results with you over the next few minutes. Thank you.
Thank you very much, Nadine, for that brilliant presentation. I think we might have lost Elaine, so I'm just stepping in. I'm sure there'll be lots of questions to ask Nadine on the back of that presentation. There's already plenty coming in. Please do remember to put Nadine's name if you have a specific question for her when you're putting your questions into the chat. So I'm going to move on and introduce our next presenter. So this is Dr. Michael Reddington, who is a spinal extended scope physiotherapist at Sheffield Teaching Hospitals Trust and an honorary postdoc research fellow at the University of Sheffield. Michael's clinical and research interests focus on effectiveness, cost effectiveness and timing of interventions for low back pain and sciatica. He's the current academic representative for the National Back Pain Pathway Clinical Network as well. And he's now going to share his synthesis of qualitative evidence of patient experiences, the care they receive for sciatica.
Good morning, my name is Michael Reddington. I'm a spinal extended scope physiotherapist and honorary research fellow at the University of Sheffield. I'm going to present to you a synthesis of qualitative study data pertaining to the patient's experience of lumbosacral radicular pain or sciatica. I'll use these terms synonymously throughout the presentation. So the plan is that I will present the three main areas of patients' experiences of radicular pain pathways, their experiences of services and their setups, and finally the physiotherapy care. We'll then finish off with how all of these can influence our care. So you're all aware of sciatica in terms of the key statistics. The numbers involved are significant, with an estimated point prevalence of just under 5% a year. The costs are equally eye-watering, upwards of around $2 billion a year in healthcare and wider societal costs to the economy. Perhaps most importantly, there are 20% or more of sufferers with sciatica who have long-term relief, no matter whether they've had surgery or conservative care at 5 years. And this is, of course, worrying that we're not reaching everyone with the current care. The radicular pain pathway is a great innovation in helping improve the variability of management of patients with sciatica in England with this stepped care approach. We know that its contents are derived from a sensible, evidence-based approach, and its form allows flexibility for local adjustment depending on local needs. What I'll present will add to the very limited evidence available as to the perceptions of pathways, services and clinical care for sciatica from a patient perspective. The patient perspective of sciatica does differ from that of low back pain, and so it's important to make that distinction. With this, it's hoped that it will provide some guidance for further improvements and also areas in which we need further work. Of Qualitative research is by nature not designed to provide population-based answers to questions, but rather it helps us to understand problems in more depth. It stimulates ideas. It provides us with important data from perspectives other than our own, and also the interesting and valuable viewpoints on which to work with. So firstly, patients' experiences, the bits that they liked about the pathways. And there were two studies which reported early intervention or fast-track treatment for patients with sciatica. Participants in both of these studies found reassurance from being seen swiftly, some patients believing that early advice as to the cause and prognosis of their symptoms promoted an earlier recovery. Other participants believed that by being seen quickly prevented further physical and or psychological deterioration of their sciatic symptoms. On the other hand, participant responses were mediated by fear, with some seeing early intervention and being offered MRI scans, for instance, as being concerning that they were being given these because they had potential serious pathology. Patients certainly appreciated being given information as to what the pathway was, what the stages consisted of, and that there was a clear and stepwise progression through the pathway. This information was given in various forms, from apps to a paper-based medium. So moving on then to what patients didn't particularly like about the pathways, and there are several elements to this. It's no surprise that among them is of course long waiting times, firstly to get into the pathway, having seen their GP first and being referred, and then the significant time delays between each of the stages. Often this was weeks, sometimes months. Patients were understandably frustrated at not being able to influence either the content or the timeframes of the stages, which made them feel that they were on a conveyor belt that they couldn't get off. Patients also found that the paternalistic element of the pathway could be frustrating, particularly for those who'd experienced more flexible pathways either in the UK or abroad, and in particular not being able to voice opinions as to what treatment, what stage of the pathway and what treatment that they would like. For instance, patients who've previously had one aspect of treatment, or for instance nerve root injections, weren't routinely offered these. So moving on now to patients' experiences of the physiotherapy services, the various services involved in the qualitative studies. And again, long waiting times for both the instigation and waiting times between treatments were a significant concern for many patients in the studies. Delays in accessing treatment were seen to be both unhelpful by some and cruel by others, who felt that delays were compounding their already quite severe problems. The feeling that on one hand, primary care wasn't speaking to secondary care and vice versa, and that these compartmentalised services added to the frustration and anger among some patients, with a view that primary care didn't have sufficient links with secondary care, who held both a surgical expertise and often MRI scan access. There seemed to be a lack of transparency as to what physiotherapy services had to offer, and often indeed why patients were being referred for physiotherapy when for a disc prolapse there was obviously a clear need for a definitive fix with surgery. Participants in one study did appreciate the practical aspects of the services, and most importantly free and plentiful parking spaces. Moving on then to patients' experiences of clinical care and what they liked in particular. And I think most of us as clinicians already know and appreciate what a good clinical encounter looks like. A clinician who listens to the patient attentively, allows them time to tell their story, appreciates their concerns and fears, and provides a format which encourages a collaborative approach to shared care and decision making. Participants in several studies appreciated a timeline of prognosis and individualised, goal-orientated care, which reflected their individual and indeed changing needs. They acknowledged the importance of timely appointments with the same clinician to help develop that therapeutic relationship. So moving on then to the patient's experiences of clinical care and what they didn't like, the concept of same treatment, different patient resonated with many participants and indeed with many therapists who felt that this compounded the impersonal service, not being able to gain the therapeutic relationships by seeing patients on several occasions at times that were suitable for the patient. Being given generic exercises and generic advice led to frustration and distress in some, and feeling that they were being perceived as being a good patient if they looked after themselves. Self-efficacy indeed wasn't particularly welcomed by patients with the most severe sciatica. I think the clinicians among us can appreciate those patients who find it difficult to make decisions and take control due to that severity I was talking about. And those patients who really cannot cope due to the all-encompassing nature of their pain. This burden of agency, and indeed sometimes the overburden of treatment, was seen by patients to be detrimental to their care and their outcome. Having too much or conflicting advice, having too many exercises, or indeed exercise that didn't make sense, that didn't change according to how the patients were doing in themselves at the time of treatment, all added to the frustration with care. So what are the pathways and service implications of what we've just spoken about? I think it's important to provide information to patients about the pathway, what it is, why it's there, why it's so important, and why it's necessary in order to improve care both on a local and a national level. It's important to make decisions with the patient about what pathway they're on, why, with clear goals which, if met, would lead to the next stage of the pathway. I think showing patients sometimes that the part of the pathway that they're on now isn't the be-all and end-all, and that hopefully they'll improve, and if not, there are other treatment options available to them potentially. Providing services that respond to individuals' need, hopefully with low waiting times and access to those agreed treatments. The practical aspects of parking and services at a time and a place suitable for the patients were all important factors in one study. Being seen by several therapists at different places at different times with great intervals between treatments was found to be detrimental to care. Patients lost confidence in services. Moving on to the clinical implications. There's certainly work to be done around the effectiveness of early intervention or fast-track treatment, who to target with that treatment, when should that treatment begin, and what treatment should this consist of? What are the elements of treatment that would be useful? From the studies, early advice and education was certainly welcomed by the majority of participants, giving reassurance about the cause of their sciatica, the prognosis, and the treatment options available along the pathways were all extremely useful. We've tried with the Sheffield pathway to provide swift access to advice at the early stages of sciatica with the hope of reassuring and mediating patients' pain. With mixed results, patients still like to talk to someone about their concerns, and I think if anything we've learned through COVID lockdown times that this has provided us with opportunities to use other means such as Zoom and technology to provide that link with patients, maybe even between face-to-face treatments. We need to move away from a rigid, linear model of cause, treatment and recovery, and accept for most patients with this recovery from sciatica, this is a non-linear event and should be expected to be as such. It shouldn't come as a surprise to patients that some periods, some days will be better than others, and that is normal. Treatment isn't always nice and linear. Empowering patients to realise this, give them a clear important challenge for clinicians. Implementation tools to facilitate this is key. For the most part, engaging patients to carry on as normally as possible without being overcome and overwhelmed by fear is a clear aim. Maintaining that normal self, going out and doing things that you normally would. You might not be able to do it for as long as you would have liked, but it still maintains some form of normality. So conclusions, and where do we go from here? This is qualitative evidence, and it will always provide a platform to illustrate what we do wrong in a lot of what we do. However, patients in all of the studies were at pains to divulge how satisfied they were with many aspects of both the organisational and clinical care they received. They appreciated the patient-centred and responsive care. What this consists of, however, and how we should develop and deliver this is certainly an opportunity for future work. We made great progress with the radicular pain pathway and need to continue with the good work of implementation and further work to determine how effective this is. Which aspects of the pathway work better than others? Are we sending too many patients for MRI investigations? Are we keeping patients too long in the primary care setting? Are we sending too many people for surgery? Finally, and I think particularly important, is that we know our surgical colleagues know how to carry out the technicalities of a microdiscectomy in order to produce relief, hopefully, from sciatica symptoms. I'm not so sure that we as conservative care clinicians have the same depth and specificity of training and knowledge for the conservative relief of sciatica. We certainly need improvements in the development of complex conservative interventions and treatment options with good treatment and delivery fidelity. All of this work would be extremely welcome and of great utility, I think, in the clinical care of our patients. Finally, I'd like to thank the authors of the work I've utilised in my talk today, which has provided stimulating, thought-provoking and challenge to my practice. This shared experience of both the clinical academic work is at the heart of the National Back and Radicular Pain Clinical Network. This acts as an important forum to share experiences in different geographical areas, in different places of our work, and sharing good practice to improve both the pathway and, more importantly, the care that we provide for our patients. Thank you very much.
Thanks for that, both Nadine and Michael. Those were really helpful presentations. We have received quite a lot of questions in the chat function, but please do add more questions if there's things that you want us to put to the speakers. The first question that we're picking up here is, why do you think that 25% of the patients didn't get better? And is there something more that we can do for them? And there's a question related to that around was it the back pain that didn't get better or the sciatic pain that didn't get better? And I'll put that to Nadine, please.
So remember that the trial included all comers into primary care who appeared to have sciatica at the GP practice. They then had a detailed clinical assessment by experienced musculoskeletal physiotherapists to be screened and consented into the trial. So these are patients with a very high likelihood of having what we'd all consider to be sciatica. But some of them, of course, already had longer episode durations. So whilst we did well of getting patients quickly into the trial, using those pop-ups where the GP put a read code or a diagnostic code in, and we got them quickly to the scopic clinic and quickly assessed, inevitably, this is a primary care-based trial, so there was a wide range of episode durations. We know very clearly from previous research in back pain and sciatica that the longer your episode duration, the more likely you are to develop chronicity. So we have not yet done a formal prognostic analysis using the data set as a longitudinal cohort to work out the risk factors, to identify those who didn't recover. So that's on the to-do list. But my strong hypothesis, of course, would be that those who already had chronic sciatica symptoms when they entered the trial are the most likely ones to also continue to be reporting that they're not recovered over 12 months. And that's based on previous research that I think we probably could have a high certainty that will at least be one of the key predictive factors. And that was only one part of that question, I think, Elaine. So remind me of the second.
So the second part was it the sciatica that got better, or was it the back pain that didn't get better? Sorry.
So to be very clear, the question on the SMS text message was about their sciatica symptoms. Of course, we captured back pain and sciatica, leg pain, but the focus of this trial was on their leg pain. And so the proportions recovered and not recovered using the SMS text messaging really did focus on their leg pain.
Thank you.
There's quite a few questions as well around the criteria used for the diagnosis of sciatica. And Nadine, in your study, it was interesting that there was a high proportion of participants or potential participants excluded because of low confidence in the diagnosis of sciatica. So I wonder if both of you actually, Michael, could you talk about what the criteria were that were used in the studies that you looked at for a diagnosis of sciatica, and Nadine, whether you can sort of then help to clarify that side of things from the Scopic trials as well.
Yeah, there's real heterogeneity and a lack of confidence in using clinical criteria for the diagnosis of sciatica. And I think we know from previous studies that they aren't great. I think probably the best or the most useful ones are that leg pain is worse than back pain. The leg pain extends below the knee. Of course, this doesn't involve upper lumbar nerve roots, so it's a little bit limited already. And you have a positive provocative test such as straight leg raise or slump. Now, I think there's only two of the papers that I found out of 27, 28 that used a robust criteria as such. Lots of it was self-report. I think in order to improve diagnostic reliability clinically, which is where we need it, we really do need to improve on the criteria we use.
And similarly in our trial, remember again, this is a primary care based trial where not all patients have an MRI scan. So you're talking about a clinical diagnosis of sciatica. So the sciatica case definition for our trial was essentially based on the assessing musculoskeletal physiotherapist being at least 70% confident in their clinical diagnosis, with at least one of the following being present. So leg pain approximating a dermatonal distribution, leg pain worse than or as bad as their back pain, leg pain worse with coughing, sneezing or straining, and subjective sensory changes approximating a dermatonal distribution, or objective neurological deficits indicative of nerve root compression, a positive neural tension test, and specifically for spinal claudication or spinal stenosis, leg pain worse with weight-bearing activities and better with sitting. So that, even that long list just tells you that we are not very good at clinical diagnosis of this condition, but it's reflective of the way in which we go about trying to diagnose sciatica in a clinical diagnosis sense.
So a question to both Nadine and Michael. From both your studies, it's indicating that the patients do value seeing a specialist, whether they have a scan or not. Do you think there's scope that should be addressed earlier in the pathway?
Michael, do you want to go first?
Yeah. I think it's understandable that patients want to see the expert and they want to see the top dog, really, which is usually the surgeon, to find out, A, what's going on, to reassure them that there's nothing serious, and to start with a treatment program. However, as we know, there really isn't any need. There's only a small proportion of patients that really do need to see a surgeon, and so I think there's a challenge for us to improve our education, both for clinicians and for patients, to give them the reassurance that the clinician that they're seeing is an expert, that they do have the necessary training and support from our colleagues, from colleagues, to ensure that they have confidence in their diagnosis and confidence in what they're being told. I think this comes down to both training at an undergraduate level and a postgraduate level. As conservative clinicians, I think it improves with forums like this, with Society for Back Pain Research, with the clinical network for the back and radicular pain pathways. I think the more that we have discussions between all involved in the treatment pathways, the better. And I think that will improve patients' confidence that they are being told the right thing at the right time.
I guess my reflection on our trial results is that the vast majority of patients in primary care with that clinical diagnosis of sciatica, and I absolutely admit there's probably a bit of muddiness there, the vast majority of patients are going to go on to have a reasonably good prognosis. They're going to get better over time. An important proportion don't, and we need to get better at identifying who they are. So in terms of the results of our trial, I guess if I was looking at this from a systems perspective, I'd say whilst patients really liked having early fast-tracked MRI scan and spinal specialist assessment, it was more expensive and did not add value. So it didn't provide better quality of life outcomes for patients, and it was more expensive. That group 3 in our trial was more expensive, and that's why on average it was £46 more expensive on average, but actually in group 3 it was over £100 more expensive per patient. So from a systems perspective, it is not wise to implement a model where all patients with sciatica get an MRI scan and fast access to a specialist. So that's from the systems perspective. From a patient perspective, you can see very clearly from our results that patients on that fast track pathway really liked it. They liked having an MRI. The clinicians on average liked them having a reassurogram, if that's the right terminology. It helped, if you like, dispel myths in those consultations with some of the spinal specialists about what was not happening in the spine, and that they didn't require anything further in terms of invasive treatments. So it must be one of those classic disconnects in healthcare where from a systems perspective, it's not needed and it's too expensive. But from a patient and probably from at least some clinicians' perspective, they really liked it. So happy to discuss that further or to have other people discuss that. I'm sure it's a really tricky one. Yeah.
And Nadine, can I just follow up on that? So there's perhaps another tension there. I think there's a lot of discussion in both the clinical and the research world at the moment about is it the best thing for the patient in the long term to scan them and to to offer them invasive treatments? And are we over medicalizing through those processes? So just before we move on to other topics, I wonder if you could, both of you actually, have opinions on that.
I think it's really tricky, isn't it? To be clear, our trial was limited to 12 months follow-up. So I'm not going to comment on what this trial tells us about long-term outcomes because we just don't know. But in the context of all that we think we know from other research literature, I guess I think what's clear to me is that, it is really challenging in the field of sciatica to identify patients who are not going to do well early on. And in that context, the current stepped care model probably seems like a sensible way forward. And it's like what I said at the end of the talk, unless we can identify really consistent predictors of poor outcome in these patients, and then only in those patients intervene earlier with either imaging or spinal special assessment or whatever else we can offer them over time when we know more, then it feels appropriate to me from a systems perspective to not be routinely offering imaging and spinal specialist assessment for patients in primary care with sciatica. And I don't want to take up too much time, but one of the things that happened really interesting in this trial is early on when we were doing the trial, and I was talking to folks who are spinal specialists, I sort of felt that they were telling me that lots of patients with really severe sciatica in primary care ought to just be fast-tracked to see them because they could sort them out, and they would add value to their care pathway and improve their outcomes. And primary care holds on to these patients for too long, and by the time they get to see a specialist, it's too late. And I know that there is some evidence from some previous trials in sciatica to perhaps support that view. But during the trial, whilst we didn't do between group arm comparisons, we had no interim analyses. Even just from the SMS text messages, we could see that the vast majority of patients in this trial on average were saying that they were resolved by 8 or 10 or 12 weeks. And so I think also there's probably a disconnect between the lens of primary care and the lens of spinal specialist services. Inevitably, in spinal specialist services, clinicians see patients who haven't done well in primary care. And so we all have different perspectives as a result, and therefore different views of what we should do for patients. I think our trial offers something new and important because it is primary care based, and it shows that the majority of patients will do quite well and do not need MRIs or spinal specialist assessment.
Yeah, I can only agree with that, Nadine. I think there are two things. There are two significant tensions at the moment, and that's with the new updates, the NICE guidance in primary care. I think primary care clinicians, GPs, are finding it very difficult to know what to do with patients with severe sciatica. Certainly now that there's so few drugs that are available or that should be prescribed, access to other services is limited. Injection therapy, perhaps we'll find out more with the nerves trial results. So they're stuck as to know what to do. I think from the very limited data that we have, what patients, I think, possibly appreciate most is having access, and what that access and what the treatment is consisted of remains to be seen. Whether that is just swift access to advice, swift access to someone who can reassure them, whether we use technology to do that, I think that's all open to debate. But I think knowing that they're in the system with access to someone to talk to is perhaps reassuring. I think other than that, certainly patients don't need MRI scans unless they have red flags, or suggestions of progressive neurology. But we need to find a better way of conveying that message to patients consistently across the board. And again, that's probably what the pathway can help with.
Dove, or a comment about in the scopic trial that the usual care arm seemed to do very well. So I suppose on the back of that, do you think we need a trial where one of the arms is no treatment? Because we know that in a lot of cases there is good resolution of sciatica symptoms just naturally. Sorry, that was directed to Nadine.
What you can't conclude from our trial is that the usual care arm intervention did really well. You can't tease out the intervention in the usual care arm from the natural history of sciatica. Unless you have a true no intervention control, you can't really conclude that from the trial. Look, what's my gut feeling? My gut feeling is that disc-related sciatica, especially those with acute episodes, probably have a really good, on average, natural history. Some people, small proportion, will develop more problems. We don't yet know how to spot them, unfortunately. We need to do more research on that. Could you do a trial of usual care versus no care? I think it'd be tough. It'd be tough to do that with sciatica. And I might say, good luck, Lucy. I wish you well on that one. Clearly, we do need more natural history research on some of these conditions, but it is tough because these patients have nasty pain, they're in distress, and our tendency in the healthcare system is to try to help them with intervention. But in a purest sense, it would be lovely to do a no treatment control trial, find out really what the effect of natural history really is.
Hi, in both of your studies, the speed of access is really much quicker than you would expect for, you know, a normal sort of service in terms of what people are receiving in the NHS. COVID's going to make the waiting list for surgery even longer. What are your thoughts about the speed of access to that first point of contact in a pragmatic world?
So in our trial, remember, we were actually trying to make faster access in the stratified care arm, so get them to the right place more quickly. And I think I presented some process data that suggested we did do that. The usual care arm had all the delays that we normally associate with NHS care, so long wait for physiotherapy, long wait for injection, long wait for surgery. So the impact of COVID, I guess, I don't know if there are any GPs listening, but I think maybe if I was a GP interpreting our trial results, I'd probably say that on average and for most patients, maybe what GPs are doing is okay, which is they're tending to hold on to them in this stepped care model and not refer them too early. And you could see very clearly from our qualitative results that generally clinicians were a bit reluctant to refer too early or consider invasive treatments too early. So how do we pull that through into a COVID-19 pandemic? Probably it means providing little more than advice, education, self-management support, reassurance, but also perhaps put in some sort of monitoring where we check in with patients to make sure that their trajectory of recovery is as expected. And then if not, to take some action without too much further delay. I guess that would be my best guess of what we should do.
Yeah, and again, I couldn't agree more, Nadine. I think that's probably the way forward, certainly in using technology as well, in assessing patients virtually, giving them access, using text, perhaps monitoring them over a period of 2 to 3 months to see how they're getting on. And if they're not improving, I say as expected, but certainly not improving to in a manner in which they're happy with, then we give them clear parameters for which we'll then send them for scans with the view to surgical options if necessary. I think managing the massive load of work that we have at the moment is really, really challenging, both in primary and secondary care, because when they get to secondary care, we don't have the resources at the moment to do the surgery that they're being sent for. So we've got the dichotomy at the moment of they've gone through the process, they know what they need, they're eligible and being consented for treatment, but they still can't have the surgery. So I think it's finding a way to manage them in the wait that's really a real challenge at the moment, and we're living with it at present. And I'm not sure we've got any answers at the moment.
I suppose one answer is to optimise their conservative management, because the surgical services are really going to be very overloaded.
Yeah, I mean, I guess it makes me think of some of the trials across other areas of orthopedics where, we do the very best that we can whilst patients are on these waiting lists. And, there's probably some good research that could be done in that space around offering conservative care in a way that we haven't done before, given these long waiting lists for surgery. And maybe through that, seeing whether more patients would then opt to not proceed to surgery, and sort of thinking about some of the work that's been done in osteoarthritis, that I don't know if that would be translatable to sciatica. It's certainly a research question worth looking at.
Yeah, we looked at that a few years ago in a little feasibility trial, and we took patients off the waiting list, because the waiting list was, again, around a year or so, and randomised about, I think, 30 or 40 patients to each arm of conservative or just stay on the waiting list. And a few patients didn't go on to have surgery, but most patients appreciated the intervention, appreciated the support. And it was mainly both exercise and psychological support that they appreciated. But we never really got round to doing that as a full trial. I think now is probably the time.
That's a good idea, Michael.
Yeah.
There's also the issue of when people are put onto a surgical waiting list that is very long. A lot of the time it means that their other treatments stop. So, I certainly think there's a role for conservative therapy for the group of people who are awaiting surgery, because those are the people who are in a bad way and have probably got the most to gain. And I think they do get neglected once they get put on waiting lists.
Michael, can I ask you a question about how you think, from what you've learned from that patient perspective, how do you think we get the balance right between empowering patients to self-manage, but also providing access to the right care when they need it?
I think this again is another really interesting question that some research would add some clarity to. I think there's probably groups of patients that, certainly the research from Kiel, I think, from Ben Saunders, has suggested that patients with such severe pain, and Claire Ryan as well, just don't have agency. They can't cope. And I think we see that clinically. Those patients who want to chop their legs off, that the pain is so severe they can't make decisions. And I think by giving clear and concise treatment plans to those patients rather than with those patients is important. I think for the majority of others, and I think it is the majority of others, it's about the providing them with the treatment options alongside the pathway, and making a collaborative decision. And I think clinically what I tend to find that works is give those options to the patient with the risks and benefits of doing so, with the timelines. So access to surgery is obviously much longer than access to physio or indeed injection therapy. And so let them make a decision. And I suppose the other caveat to that is you can't go back once you've had surgery. With physio, there are very few risks. And on the whole, benefits to be gained. But I think that collaborative decision making in terms of the different groups is important.
Could I come in and just definitely respond to Anne Magnon's question around our algorithm? So absolutely, goodness, we were trying to develop an algorithm with very limited evidence base. And I think we did a reasonable job of thinking, let's combine prognosis with some sensible clinical indicators. And so we used that previous cohort of sciatica patients in primary care to try to identify the things that predicted referral to spinal specialists at some point over that 12 months. And to answer your question, we did use a sort of combination of data and clinical nous, as I call it. So we had a clinical advisory group. So 3 of the 4 clinical severity indicators came from the data, and 1 came from the clinical advisory group. And that's all explained in the paper that I mentioned that describes the development of the algorithm. Believe it or not, pain below the knee did not come out as a predictor of onward referral to spinal specialist services in that cohort, but absolutely clinical nous from the clinical advisory group said we absolutely want pain below the knee in there as a clinical indicator that should be considered before referring someone to see us in spinal services. So it was a bit of a mix in the end, rather like most of our work, I think, in the team at Keele, really trying hard to make sure that what we do is clinically relevant and has a high degree of clinical sense making around it. I think in truth, that algorithm may not be fit for purpose. It may have simply referred too many people into that fast track pathway that didn't need to be there. And so again, if you're listening and you're interested in this area of work, trying to work out better models of predicting who needs to see spinal specialists, there's really lots of work to do there, I think.
There's an interesting question come in about the role of remote clinics, given that the prognosis is reasonably good for a lot of these people, but they actually get benefit from speaking to someone who's a spinal specialist. Is there a role for remote clinics rather than bringing everyone in?
Yeah, I think so. Absolutely. I think clinically, I work in secondary care with spinal surgeons, and that's what we've been doing for months now. And patients appreciate it. They appreciate not having to park, not having to travel, not having to take a day off work. They get a chance to discuss their problems with the consultant or the consultant's team. And I think from a clinician's point of view, it still works. You're able to convey the message to the patient. You're able to discuss their MRI scans and treatment plans, treatment options with them. Probably, in a relatively the same way as you would face to face, without, of course, the risk to patients and the problems that come with coming to hospital, certainly at present.
And look, there's reasonably good evidence, at least if not in terms of this type of technology, but certainly in terms of telephone delivered, assessment and advice and treatment services. There's reasonably good evidence that on average, outcomes are similar when you provide care in this different way than when you provide care face-to-face. I don't think we have that evidence specifically for sciatica, so probably that's a good research question. But in other musculoskeletal disorders and on average in musculoskeletal pain problems, I think we do have reasonably good evidence to say telehealth, telerehabilitation provides equivalent outcomes to usual in-person care. So, I think the COVID-19 pandemic will be transformative, and probably a lot of the way we're working will stick.
Thank you. I'm going to wrap this session up. It's been really, really good and a great time for discussion. There is some more information in the resource centre, and the speakers are often available in the network lounge if people want to go and explore that as well. But thank you for all those that have participated. Great session. Thanks to our speakers. Have a good day.